Hi, I'm Dr. Kirti Magudia. I'm a diagnostic radiology resident at Brigham and Women's Hospital.
My name is Dr. Thomas Ng. I'm also a diagnostic radiology resident at the Brigham and Women's Hospital.
Welcome to episode 19 of the Post-Call podcast by MD Edge. I'm the host of the show, Medical Muggle Nick Andrews. At MD Edge, we know that medicine can be a bit of an awakening at every step of your career, from med school to residency to fellowship or on to practice. So this podcast is all about sharing your stories, what you love in medicine and what you love outside of your career. Here, we want to draw on the things you love and help you find your truth. In this episode, I talked to Dr. Kirti Magudia and her colleague Dr. Thomas Ng about their recent research on paternal leave for trainees among the top medical schools in the U.S. Remember, you can email the show at podcast@mdedge.com and even have your comments or tips and tricks on burnout read on a future episode. You can follow me on Twitter at TRIBNIC, that's at TribNick, which is also available in the podcast notes. And now, part one of my conversation with Dr. Magudia and Dr. Ng. So I am here on the 13th floor in a very beautiful part of Boston on an overcast day, and we're talking about a research letter that came out at the end of 2018 about parental leave in major institutions, written by you, Dr. Magudia, and you're an author on it as well?
I am an author on it.
So the most striking thing to me, and I wrote this story for MD Edge, I was involved in the reporting of this, the striking thing to us was that it was brand name institutions and that the time off, the leave for having a child was not at all what one would think it should be. But what did you guys find, and how did you start by asking the question?
So I think, anecdotally, we know that there are residents out there who, specifically mothers who go on parental leave as residents and maybe get 2 weeks or 4 weeks, and that's just their vacation time. And then they have to go back to work and they have no more vacation for the rest of the year. And that seems, very difficult. And we wanted to really know, what are people facing out there at these top training institutions? So we looked at the top training institutions associated with the top medical schools in the country.
Like things you could look up, like you could Google like the top 20 or top 10, and like these are those schools.
Exactly. So we went to the top 10 lists, and we went to two different sources for that, and in the end got a list of the top 12 medical schools, looked at the training institutions associated with those top 12 medical schools, and then very carefully asked each of those institutions what their parental leave policies were for residents.
And I'm assuming like all the heavy hitters were there. You got Harvard and Penn and Stanford and all the big dogs were there. And so that means you're spanning all 4 time zones. It's nationwide.
Yeah. We spend a lot of time firstly getting publicly available information, and then obviously to confirm with them to get the latest up-to-date policies through the JAMA offices. Was there ever a point where you were looking at it and you think this is pretty interesting? These numbers are worse than I thought. Before you published.
Yes, definitely. I mean, that was the first thing that hit us. First of all, even before getting the numbers, it was incredibly difficult to get confirmation of the policies and to even find out what the policies were for certain institutions. So if it was so difficult for us, then imagine what it's like for people in those institutions. They have no idea what's available to them.
And did you find any discrepancies between time off for men versus women?
There's definitely the discrepancies. On average, I think time off for the women, the mother, usually significantly longer than the non-childbearing parents. And in some places, the non-childbearing parent is not even mentioned in the policy.
That's really interesting. So it's not as long as it would need to be for the childbearing parent, and it's not even necessarily relevant to the institution for the non-childbearing parent. So that means that the fathers, if you will, or the non-bearer would have to use just straight up vacation time.
Yeah, that's often the case. Even for in certain cases for the mother in the situation might need to use vacation or sick leave, for example, to actually contribute to the parental leave.
What did you make of all this when you sat down and had it and it was time to write something? What did you think?
So we just thought that it was really interesting that half of these institutions don't have parental leave policies, and that even of the ones that do, what they're offering is less than what's offered to the faculty. So all of these training institutions, so we looked at a list of 15, had faculty policies. And on average, I don't remember the exact number, but it was significantly higher than what was available to the residents. And again, as Thomas said, for the childbearing parent, it was longer than for the non-childbearing parent. So we were thinking that just making this information available alone would lead to some change. And in fact, since most recently the partners policy which covers both Brigham and Women's Hospital and Massachusetts General Hospital, has become more generous and now is 8 weeks for both the childbearing parent and any parent regardless of childbearing status, which we think is hugely positive.
Yeah, that makes a lot of sense. I think also it is, if like, off the top of my head, I believe that is pretty close to what like the general public gets. I think it's like 10 to 12 weeks depending on where you work, which is a huge step in the right direction because physicians, residents usually get nowhere near that regardless. But the real striking thing to me was that this was happening at the highest institutions, who are all, I am not stepping out on a limb to say, financially capable of figuring it out for 6 weeks. But it's happening there. Do you worry that it's happening at other institutions who are not in the top 10, 20, 30?
I think totally. I think, as you mentioned, the top institutions have manpower resources, financial resources, potentially absorb the impact of someone stepping out. So I can imagine small places or places which are potentially don't have the resources, as you mentioned, those things aren't going to probably be better, likely to be worse.
So we were talking before we got going, and you have a boy, and you have two. How many children do you have?
I have two. I have one girl and one boy.
So were you, for your participation in the work, were you particularly motivated? And Kirti, do you have children as well?
Yeah, I have 2 children.
So what were your experiences, if you would like to get into that, and was that part of like your motivation for looking at this?
Definitely. I had both my kids during my clinical training residency, one during my intern year, which was not in Boston, elsewhere, and then a second one in the during residency here. I think my initial first during intern year, I had no idea actually about parental leave policies, and I was fortunate that my program administration worked with me to organize my schedule so that I had a little bit of time off during the birth of my child for a few weeks. But it was difficult to sort of work that in within the training timeline. Really, there was not much of a guidance from a policy perspective. And then during the second child, partners, as we mentioned, had a little bit more standard policy, which allowed us to sort of work with the administration to organize our child leave.
So I had my first child at the end of medical school as a 4th-year medical student. Both of us did dual degree programs, so we did both medical school and PhD work. And so one of the reasons I chose my MD PhD program was that they were the first MD PhD program in the country to have a parental leave policy. And so I saw some of that vision kind of at an earlier stage. So I had a lot of flexibility as a 4th-year medical student with that first child. And then I had my second child during my first year of radiology residency at the Brigham.
So pretty close.
Pretty
together.
close.
Yeah, like a couple years, right?
Couple years apart. And I think what struck me is that, they had a specific policy at the Brigham, and it was actually very easy and a smooth process. So they, went ahead and rearranged my schedule. I had protected time, and everything I thought went very smoothly in terms of parental leave.
So now that like you guys have these experiences so you know firsthand what it's like anecdotally, and now you have the data as well. I'm wondering, without getting too much into the planning of what your families are like, what do you think about this coming up in interviews for matching for residency, for fellowship, or even becoming a faculty member? Do you think it's inappropriate to ask, like, are you planning on having a family? Are you planning on getting married? What does your life events look like as well?
So it's against the rules to ask anything about family, marital status, children, any of those sorts of questions during residency interviews. It doesn't mean it doesn't happen.
Sure.
And I think it's awkward because I think there are going to be specific applicants who want to know this information but don't want to tip off necessarily and kind of affect how this ranking process is going to go.
And do you think the major motivation is that the hospital doesn't want to deal with like having to figure out what to do with this person's absence for 6 to 8 weeks?
I mean, it's a complex situation, right?
Sure.
I mean, there's the whole dynamics between colleagues and also administration. There's definitely a signal of economic impact, but also a sort of cultural workplace impact as well. You have someone that is not there who's contributing the workflow, and having that absent for a while can have an impact on everybody else.
What was it like for you guys with your co-residents and your fellow students and people that you worked with?
I had a very positive experience. I think the fact that our department had a fixed policy that we can look to allowed us to plan our schedules in a framework which would have the least impact on the schedule.
I think also we're lucky because our program's on the larger side. We have 10 residents per year, so
Wow.
the absence of one resident doesn't make a huge difference necessarily. versus other places there are radiology programs or any other residency programs that may have
Like 4
two
to 5,
residents
yeah.
or a handful. Then having one person out makes a huge difference to the running of the program.
Because it is a higher proportion of like the workload, right? That makes sense. So now that you have the findings, what's next with this line of work?
So both of us are working actually on a related paper looking at what the needs of trainee parents, so both residents and fellows, are in terms of issues related to parenting. So parental leave is one of them. Then looking at childcare and also lactation support.
Oh yeah, so I just I got to sit on the grand rounds at an unnamed institution in the Philadelphia area, and the grand rounds was on surgical residency with women, and the topics of lactation, parental leave, sexual harassment, gender bias, a bunch of things came up. The lactation stuff is really interesting because it appears at some hospitals, I don't remember the study, but we do have the data. Some places are just ignoring that, which is crazy because it's a hospital.
I can speak with personal experience to this. So after I came back, with both children, but with my second child, I came back to residency and I was breastfeeding. So I was pumping during the daytime when I was at work. Radiology is a little bit different than some other specialties because you're sitting in a reading room and everyone's kind of with each other. So your absence is noted when you leave the room.
So it's like taking a restroom break, except it's a lactation break. All right, guys, see you later. Be back in 10 to 20 minutes to let you know how it goes.
So that's the thing is there's so many misconceptions about pumping and what it's involved, how often you have to do it, how
Sure.
long it takes. And the realities are that 10 to 20 minutes is actually not realistic. It takes time to, first of all, walk to the room, to kind of get set up, to actually do the whole process, to go back. So it might be half an hour.
Sure, and the process is also really complex as a whole process because you can't get behind, right? That creates a huge traffic jam, and that's no good. But also every time that you take time out of your day, like it becomes a bigger hindrance for other people around you. And like, am I putting you out by doing this? Like, when can I do it? And for hospitals to need to address this problem where medicine is practiced, that really blew my mind seeing that.
Exactly. I mean, again, we're lucky to be at Brigham and Women's Hospital. So we have multiple, lactation rooms, but even with the ones that are available, that are in existence, they're not necessarily available when you need them. They're not in a convenient location necessarily. They don't have a computer and a phone so you can continue working while you're pumping. All of these sorts of issues kind of make it a little harder. So we looked at all of these things in the study.
And to be fair, I think the institutional graduate medication body as a whole has recognized these problems. I think they've recently changed their policies to such that starting from 2020, programs are necessarily need to have appropriate lactation facilities in the institutions where trainees are training. And so I think that's one step in the right direction.
Yeah, that makes sense to me.
I think it's the actual facilities, but it's also the culture of being friendly towards people who want to do this and supportive.
That's really interesting that you mentioned that because the post-call podcast was I wanted to do it because I thought that this was sort of lacking where people in medicine just talked about their life. It's also, we try to address physician lifestyle, clinician lifestyle, and burnout is a big part of that, and it's all connected. It seems like when we talk to people like high-level academicians, when I get the opportunity to interview those people, they say that residency used to be a residency, and you used to hang out when they were your friends, and you lived there, and everybody was buddy-buddy, and gradually over time it became very cold and competitive. But that a return to the camaraderie that was experienced possibly in the 60s and 70s, and this is just previous episodes we've done, can create supportive environments where if you knowing more of the personal life or being friends with the people that you're working with in med school, residency, and fellowship can improve those things. Like you said, if there's a supportive environment from the top down, including the people you're around, I think it could probably foster a better experience. And then not only would that be better for whatever you're trying to do, with lactation or family planning, or just make everybody feel like they're part of the team or the family, if you will.
And I think that contributes to you performing your job better. I mean, if you're happy and you feel supported, you're naturally going to give more concentration to your job, and ultimately that's leading to better patient care.
Yeah, I mean, that makes sense to me, right? I mean, like what I found, and I've said this on this show a couple times, when I started my career in medical media, I had to schedule an interview with a high-level French oncologist, and I could tell that he was so annoyed that I'm like, all right, just get this done. But when we started getting into the science and the medicine, he became really motivated. So when you focus on the patients and everything else is trickling down, and there's no EHRs, and like your lifestyle things are not a huge, crazy problem, everybody benefits, including the patient. I'm a patient as a muggle, and I would like that if everybody wanted to do the thing that they started out to do.
I mean, I think the problem with residency is it's so rigid. You get, you sign up for this residency, you have to do it for a certain number of years, you have to be at a certain place at a certain time, the hours are long, and there's just not that much flexibility. And so I think the better the work environment, the more flexibility you kind of can rearrange your schedule with your colleagues and those sorts of things. But
Sure. Like if it was like the work environment that's experienced by the general population.
Yeah.
Where you can just go and be like, well, why you people over there, this looks so nice. Why is it not this way for us?
But I think it's also, I think people now are starting to recognize that, and people are experimenting with different hours so that, for example, doctors can see a doctor during the business hours, for example. I think a major challenge, like you don't recognize, like a lot of doctors put away their health problems, health issues for a long time because they just physically can't get away to see a doctor.
Despite being in a hospital, and
Right.
you don't have like where the specific hospital insurance covers, you get an outpatient place, which is a different location. You can't just walk down the hall, which is crazy. That's so counterintuitive to everybody. Like, why not just go ask your buddy, like, hey, check this out real quick, please.
I think another important issue to touch on is the issue of like specialties. So I think both Thomas and I are so lucky that we're in radiology, and the way that radiology training is structured, we have flexibility in time. And so we can take these parental leaves and not delay graduating from our programs. But you brought up surgery. So for example, in surgical subspecialties, generally it's a lot more rigid. Your clinical time is measured. You're not allowed to be off of clinical time and graduate on time for very long.
And the case numbers are really competitive. Like can I get case numbers that's like and I know that there are other procedural, like interventional cardiology, different like programs that have those problems as well. Like I need to see the appropriate amount of events so that I can check it off my list and get done with this.
Yeah.
And I imagine taking out leave would set all of that back.
Exactly. And I think that, what that actually ends up meaning is that even if places have these institutional parental leave policies, because there's board requirements by specialty, the actual parental leave that someone might end up taking could still be less, even if the institutional policy is very generous.
Interesting.
And I think that interplay is very important to kind of understand how complex and dynamic the issue is. And that's why there was another article that was published at the same time as ours in JAMA that looked at all of the specialty boards to see, if they even mentioned parental leave and how that was addressed. And I think that it's just a major thing, and we're hoping that those sorts of changes will happen so that, people in surgery and other specialties will have the flexibility to take the parental leave that they, need.
That makes sense. So to me, it seems like an economic issue where one group of to get two people bargaining, right? And I look at it a lot like sports or like any other union, like maybe actors. And you're just like, this is like the service that I'm providing, and this is like the rate at which I want to do it. And there's a recruiting element to that. But because residency is matched, and in order to become a real doctor, you have to go through medical school and residency and then possibly fellowship and then whatever else comes after that. So one group has all the power, right? But you want to buy into the system so you can work your way up. At the same time, you have no bargaining chips. Like, if you want to be one of us, you got to do this stuff, and we did it. And I think that fosters like a real sort of resentment. And it's really interesting that a handful of residents I've seen, a couple in surgery and a couple in medicine, they start out ideological when they begin, and then they become converted to the system by the time that they're attendings because the system broke them. And I think that's what's leading to like all these fights. But that's just me guessing.
I think this paper, having published like what the leave policies are, this could really affect where people choose to go for residency.
It's a big mirror to some big names, for sure.
Exactly. And I think, it will lead to change. So this is not a static situation. I think over time these policies change and can improve. But I think it's going to motivate a lot of places to improve their policies and to make them publicly available so that when medical students are applying for residency, it's going to be clear to them what the offerings are.
Yeah, that's really interesting too. Like, I'm a millennial. I think everyone in this room is like a millennial or at least close, and maybe identifies as a millennial. And our generation, this generation, is starting to choose lifestyle over other things, over glory or fame or financial accolades. People are taking pay cuts to do the thing they want to do, saving more money. There's a step back from just the upward mobility that was experienced in generations before. And I think that when I read this, I thought that exact same thing. Why not take a residency, like rank somewhere else higher that has a better policy? Well, you would think about that immediately if you were thinking about having a child in residency. I would assume.
Right, I think having that life factor on top of the clinical training, you want to take the big picture and take a step back. As you mentioned, like, gone are the days where you're 100% inside the hospital the whole time you're training. There are so many things that you need to learn about, from clinical to the extracurricular stuff. And so having all the information, all the support in all different aspects is only going to help you. So.
And like being able to have the conversation out in public, which I love podcasts for that reason. You can just kind of turn it on, and this is unedited, so that means that for the most part, the stream of consciousness allows you to finish your thought and you get the full idea instead of just the soundbite, which is, I think, really important. But I want to switch gears a little bit to you guys individually and what your life will be like, hopefully, in 10 years. What are you going to do?
So I'm closer to the end of radiology residency at this point. I'm next going to do a year of a research program, and followed by a clinical subspecialty fellowship in
Which, what are you thinking?
Abdominal imaging and ultrasound. So in our special, for radiology, we actually have to pick our fellowships very, very early. So I've known for almost 2 years.
That's nice. So you've had your soundbite to that question. Like you're ready.
Exactly.
For that.
I've been ready.
Right.
I've been ready. And then hopefully, I'm planning to continue to work at an academic position, combining, clinical teaching and research responsibilities.
Yeah, so like you've got this sort of meta study out now about parental leave, but then I imagine like the clinical aspects of your career will be a completely different thing, and maybe you can marry them, maybe they'll be different. It'll be a lot of exciting challenges. But what about you?
Similar, I think, both as we mentioned earlier, Kirti and I both did graduate school, and so that part of our lives are very important. And so I'm going to subspecialize in nuclear medicine and molecular imaging over the next year or two. And then hopefully after that, we'll continue an academic career trying to combine the clinical and the research.
So how does it work after your residency? Is it a match scenario again, or is it you apply?
So some of the radiology subspecialty fellowships are a match,
Okay.
and some of them are not.
Okay.
And I think there's benefits, pluses and minuses to both of them. I actually enjoyed my fellowship not being on a match because it meant that at the end of the day, you still get to choose the individual institution you want to go to.
Yeah, and that means that you kind of like decide where you live and like maybe not pack up and move. Is that a similar circumstance that you're finding?
Yeah, so one of the good things about our resident program is the flexibility that's been built in for the last couple of years. And so I'm actually going to stay in the same institution for my further specialties training. And we've managed to sort of incorporate some of my fellowship training up front so that there's a little fluidity between what I'm learning now and what I'm going to learn in the next year.
Yeah, so it all lines up. That's really nice. But you both plan to stay in the Metro Boston area?
For the foreseeable future now, but who
knows,
knows,
right?
right?
Yeah. There's a big old world out there. I tell it to people all the time. But where are you guys from originally, if you don't mind me asking?
So I was born in London, but I grew up in the Bay Area in California, and I went to Berkeley, as did Thomas actually.
So you guys have crossed paths a couple times.
Yes.
Maybe.
Maybe. We didn't know each other back then, but I'm sure we saw each other. And then I went to New York for my MD PhD training, have been here for residency, and I'm actually returning back to the Bay Area.
So that's where you're going?
Yes.
Yeah, Northern California. That's a long ways away. It's all the way out there.
So I grew up in Australia, and then
I thought I heard it. I didn't want to ask it. It's always inappropriate to ask about accents. I knew it. Yeah.
Then I moved over to California as to the Bay Area, as Kirti mentioned, for college, and then slowly my accent's diluted.
Yeah.
I stayed in California for like all my school training, and I took that deep dive to move to the East Coast to do my resident training in radiology.
I always find it interesting when you pack up and move. So I was born in Wyoming. That makes me the rarest Pokemon. There's not very many of us out there. And then I went to college in Mississippi, and then now I live in the East Coast. And it's always fascinating to get the culture shock of like this is one nation, but there are all these sub-nations. The Bay Area is way different than Boston. Way different.
Well, I live in Cambridge,
Okay.
and I would say that Cambridge and Berkeley
Sure.
are actually similar.
Yeah,
they
fair
have
enough.
a shared like culture.
Yeah, that makes sense.
And so
yeah,
it
I
makes
can
me
see
happy
that.
to
I
be
haven't
there.
spent a lot of time in Cambridge, but that makes sense. The elite college atmosphere can kind of be transferable, I suppose, right?
Well, it's more the diversity, like the
Okay.
diversity and the egalitarian kind of
makes
feeling.
sense. So Harvard is in Cambridge, but MIT is close by as well, right? And then there are other institutions there, or are those the two main ones?
I think it's the two main ones.
Okay.
Yeah.
But what has your experience been? Because you guys have moved all over. But if you grew up in the Bay Area and were born and spent time in Australia, what do you think about the importance of moving around countries or the country?
I think it only benefits you, I think. Having that experience throughout different places, I felt like, when I meet people in new places and we talk about there's shared experiences, it's a lot easier to sort of start conversation, make friends, etc. And just learning about different things in the world, like once you starting reading newspaper, sort of everything is in context, it makes sense. And you can relate to a lot of patients, friends, random people on the street. It's fun.
It almost feels like I would imagine that like where you are would impact patient care because the context of how people live their lives are different from one area to the next. I mean, the science is probably, I would assume, the same, but also like the experiences of your patients from a patient-to-patient basis would be different.
Well, I think like science is also different too. Like there's certain diseases that are more prevalent in certain geographic areas, and or certain practices which might be conducive to certain diseases in certain areas. And if you don't know about those things at that certain area, you might not think about it. So that's I think that's very important.
Yeah, I mean, I think about it more from like the people context and kind of the people you get to know in each of these areas. So I think it's one thing to kind of move from place to place, but I can look back at my PhD experience and think about those people that I got to work with, how valuable those relationships were, how I want to keep in contact with them forever. And it just happened to be the right place at the right time. And it's the same thing for residency. So I have Thomas in my class. There's other people in our residency that even though we're all going to scatter across the country and maybe across the world, we hopefully will stay in touch forever. And I think these are really deep and important relationships.
Yeah, I agree. I think that it's I also am touched by the internet. I think that everything, just like, I call it the Nobel complex. I'm sure someone much smarter than me has a real term for it. But Alfred Nobel invented dynamite. Everything is equally as good as it is bad, right? So the internet can be this place of social anxiety, and there are bullies, and the anti-vaxxer stuff is crazy. And that's just in medicine, and it trickles down to all the other aspects of the world. But it also gives you an avenue to stay in touch with the people that you met, and now you get your contact information. You can check in on other people and see how they're going. But having that opportunity to stay in touch with people that you went to med school with or undergrad with, I imagine is probably pretty cool.
Yeah, I'm hoping that at the end of the day, Thomas and I end up at the same institution. That's my goal and hope.
Yeah. And that concludes the 19th episode of the MD Edge Post Call podcast. I'd like to thank Dr. Magudia and Dr. Ng for taking the time to sit down with me. And don't forget to check out episode 20 for part 2 of our conversation. For all of us at MD Edge, I'm Nick Andrews, and this has been the Post Call podcast by MD Edge.